It is really great to be here, and I really do love spending time talking with parents and families about the issues that I'm going to talk about. And the thing that I've found that I like almost the most is the open question and answer period. So what I'm going to do, I'm going to speak for no more than 40 minutes, maybe a little less. I'm going to give you some important facts, really, and give you some perspective about how we at the National Institute of Health think about a subset of emotional problems in children and adolescents. But then what I'm going to do, really starting at a quarter after, I'm going to open it up to any question that you have really about anything. Baseball is my second thing that I know a lot about, so it can be about baseball as well. As I mentioned, I'm going to talk relatively narrowly. I'm going to talk about emotional problems in kids, and there's really going to be two parts. The first part is going to kind of be what we know now. So really what we know about how to diagnose and treat different kinds of problems. And I'm going to really be talking about three things in terms of what we know now. Diagnosis and outcome will be the first thing. Familial aggregation will be the second thing. And treatment will be the third. And while I will have a lot to tell you in this first part, one of the difficult things is that there is very much more that we need to know. And I think most people agree that the way that we're going to get to the next level in terms of what we know is by studying the brain. And that's how I actually spend most of my time at the NIH. So I am going to talk to you a little bit about what studying the brain is teaching us, and in particular, when and how it might be clinically relevant. So that's really what I'm going to do. And I'm going to be talking about two sets of problems. I'm going to be talking about mood problems, first of all, and the main mood problem that I'm going to be talking about is something called major depressive disorder. So this is a relatively common problem. When we follow kids longitudinally, we find that somewhere between 5 and 20% of American children at some point before their 20th birthday will have what we call an episode of major depressive disorder. All right? So when physicians talk about depression, they're talking about a very particular thing. And that's really what I'm talking about when I talk about major depression. This is not the same thing as having symptoms of depression. And in a second, I'll tell you about the difference. So this has to do with how we draw a line between when depressive symptoms are normal or abnormal. And it's very difficult to precisely draw that line. And we tend to use a relatively high bar when we consider that a child has a diagnosis of depression. And there are really two things that go into that. The first thing is the timing of the problem. When a child has a diagnosis of depression, it has a very particular temporal course that involves a low or irritable mood every single day, all day, for 2 weeks or longer. All right? So that's a very high bar to have. So having symptoms of depression is common. Meeting that temporal bar every single day, all day, 2 weeks or longer in a row. You have to have that. The second rule we use is something called the impairment criterion. And what this means is that the depression that the child has interferes with their ability to do something. It virtually never happens that you see a child who meets the time-related criteria that they're not impaired. They're always impaired if they have depression every day, all day, 2 weeks or longer. There are a lot of kids who don't meet that time criteria but are impaired, and we kind of struggle about how to think about those kids. We know that they're highly at risk, but we don't generally give them a diagnosis of depression, and a lot of what I am going to be saying about treatment, we don't know how well that applies. There are many different ways that depression interferes with how kids function. It's much less complicated in thinking about this relative to problems with anxiety that I'm going to talk about in a minute. Kids who have depression are really massively impaired, and anybody who's seen a depressed child knows that. There's a very interesting relationship to age and gender. So the rates of depression are very, very low before puberty. And then with the hormonal onset of puberty, there is a dramatic increase in the rate of depression. And there are two things that we know about that increase. One is that it particularly happens among girls. So it does happen among boys, but it happens even more among girls, all right? And we know that it's related to stress. So there's something in particular about interpersonal stressors after puberty that are particularly difficult for girls. Now there's a lot more we don't know, and I know there'll be questions about that we'll talk about, but remember those two things about age and gender because we're going to come back to them when we talk about anxiety. The big thing about major depression and why we worry about it so much is once it's established, it's very difficult to treat. All right? So a lot of people, including myself, think that the best way to handle depression is to really treat the precursors. And what I'm really going to talk a lot about are anxiety disorders, because anxiety disorders are the most potent precursors, the strongest predictors of having major depression. I'm really not going to talk about bipolar disorder. This is something that we spent a lot of time at the NIH studying, and anybody who has any questions about really any emotional problem, I left a lot of materials at the back, and I'm gonna end. My last slide has my phone number, and you have my phone number, so you can totally call me about that. The main thing to say is that the prevalence of bipolar disorder is very low. It is a very rare disorder, much rarer than anything that I'm going to talk about tonight, and that's why I'm not talking about it much. And it's also controversial in that there had been a tendency, it's a tendency that we think is reversing, to be overly inclusive with that diagnosis, all right? So those are the mood disorders. Now we're going to talk about anxiety. So there are many different kinds or flavors of anxiety. Really, for the purpose of this talk, you can think about three flavors. There's OCD, which is obsessive compulsive disorder, and this is a very particular stereotyped way of having concerns about a particular bad thing happening. So the most common things are concerns about cleanliness. So an obsession that a child with OCD might have about cleanliness would be that they're in some way dirty, or they've sinned, or they're contaminated in some way. And then another one is checking. So a very common one would be that they forgot to lock the door, or they forgot to feed the dog, or they forgot their homework. All right, so they're very particular and very stereotyped. That's an obsession. A compulsion is an act or a thought that's designed to reverse that. So if you're thinking that you're dirty, you would wash your hands. If you thought you forgot something, you would check it. All right, so that's OCD. It's relatively rare. PTSD is another group of anxiety disorders that happen after a child has suffered from a life-threatening, that's the key thing, it's a life-threatening traumatic instance. And the key thing about OCD and PTSD is that they are both relatively unique in terms of what happens to kids with these disorders and their biology relative to all the other anxiety disorders. So those are things like phobias, generalized anxiety disorder, separation anxiety disorder, panic disorder, and I'm not going to make any differentiation among this last group of anxiety disorders because the similarities among those groups are much greater than the differences. So these are much more common than major depressive disorder. About half of all kids, when we follow them longitudinally, will have one of these problems at some point in their development. It's much more difficult in the anxiety disorders relative to the mood disorders. It's much more difficult to make this distinction between what's normal and what's abnormal, all right? And the field really struggles with trying to understand this, and we cannot draw anything like a clean line and say this child definitely has it and this child doesn't have it. The rule that we use, though, and the simplest rule as a parent that you can use, is that you look for signs of avoidance. We know anxiety is abnormal, we know it's a problem if that anxiety prevents a child from doing something that other kids can do. If it prevents them from making a presentation in school, if it prevents them from going to a party, if it prevents them from talking to somebody that they need to talk to. So that's the simplest rule to use, and that's what I recommend to parents. The problem is there are other kids who do not have avoidance, but they suffer. All right, they suffer from a lot of distress from their anxiety, and that's where the problem really comes in. When is that amount of suffering really too much? And that's the problem that we have as scientists. There's also this very interesting relationship between age and gender with the anxiety disorders, and the key thing to know there is that the bump in anxiety disorder starts much earlier. It starts in school age, and it is more common in girls than it is in boys long before puberty. So that made many of us think early on when we were beginning to do research on anxiety disorders that anxiety disorders are precursors to depression, and I'm going to talk about that in a second. So this is a study that I spent about 20 years doing. I used to say when I do look younger than I am, but I used to say I'm older than I look, but you know, now I've been in the game for a while, so it's believable that I would spend 20 years on this study. But the key thing about this study is it randomly sampled kids from 2 counties in upstate New York. So it collected a representative sample of kids, and it followed these kids over 20 years, and it serially assessed them with structured psychiatric interviews. And what this slide shows you is the relationship between having an anxiety disorder at some point in adolescence, and I'll walk you through exactly how it shows that, and having any kind of emotional problem, a mood or anxiety disorder in adulthood. And again, I'll walk you through the data in a second. The important thing to say about this, there are really 2 big things to say. The first is this is the particular study that I like to talk about since I did this one. But when we look at many, many studies, we find exactly the same thing. And then the second thing to say is, and I'll say this when I get to the end of talking about this piece of data, we see very similar relationships for all kinds of chronic mental health problems. And these kinds of relationships lead many scientists to say things like mental disorders are primarily disorders of the young or disorders of brain development. And again, I'll walk you through that in a second. So there are 3 main points to take away from this slide. Point number 1, this looks at how many kids at some point in adolescence had a significantly impairing anxiety disorder. So you can see the bar here is set high, higher than what might be accurate, but still, even with this high bar, 253 of the 679 kids had one of these severely impairing anxiety disorders. Point number 2, when we followed these kids over 20 years, most of them did well. So not only did they not have an anxiety disorder, they didn't have any emotional problem when they were an adult. 191 out of the 253 were fine. So anxiety problems are common, they usually go away. Now, many people think, okay, so why are they important, right? If they usually go away, why are they important? The reason they're important is point number 3. When we look at the adults, there were 100 adults in this sample who had a serious emotional problem. Of the 100, 62, or 98 to be exact, 62 of the 98 had their problems start when they were a kid. So what this tells us is that anxiety is very common, number 1. It usually goes away, number 2. But that minority of children who have persistent anxiety will grow up to account for the majority of emotional problems in adults. All right? And then the last thing to say about this, a point I made a couple minutes ago, if we were to look at any chronic mental health problem, substance use disorders, personality disorders, eating disorders, behavior disorders, the list goes on and on and on, we would see exactly the same thing. Problems in children are incredibly common. They usually go away. All right? So most mental health problems are treatable and they go away. But that small group of kids who have problems that don't go away will account for most mental health problems in adults. And that's why it's so important that the country takes very seriously this issue of mental health problems in kids. Because not only does it impact children, but it really is fundamental to impacting mental health disorders across the lifespan. We see a very similar thing when we look in families, that these kinds of problems run in families. Parents with depression are particularly likely to have kids with anxiety, and we think that this is another sign of this precursor. Both genes and the environment are important. So in particular, when we think about things like anxiety and depression and other common mental health problems, there are no what we call big gene effects. That means there isn't one gene for any of these problems. There are many, many genes that each make small contributions. Moreover, when we look at the overall amount of importance of genes in the environment, they're both important and they both interact, and we don't like to say one is more important than the other, but if we had to, we would have to say that the environment is more important than genes for these kinds of problems. And then the last thing to say is, so what's the lesson about this, particularly if you're a parent and, you know, I just said this and you're probably cringing. The important thing to know is when we do these family studies, what we find is that there is almost never one big thing that creates risk in any individual child. There is an incredibly complex web of things that interact in very difficult to understand ways to give rise to problems. So there are things that you can do to help your child, all right, but they interact with many other things, and that's what makes it so hard to treat some of these problems. And you know, we can talk about what are those specific things if you have questions in the question and answer time. All right, so very quickly, in maybe 5 to 7 minutes, I'm going to talk about depression, I'm going to talk about anxiety, I'm going to talk about treatment, I'm going to go over a huge amount of detail, but there really is just two bottom lines, all right? Bottom line one is that there are two kinds of treatment that I'm going to be talking about. I'm going to be talking about selective serotonin reuptake inhibitor medicines, and you're going to see all the names. You have all the names, so I'm not going to say them. And I'm going to talk about cognitive behavioral therapy, CBT. All right, that's all I'm really going to talk about. And the reason that I'm talking about those is that the best kind of evidence that we get for treatments are from a particular kind of study called a randomized controlled trial, or an RCT. This is a very difficult, expensive study to do, and we need many more of them. Most of the treatments that we use have not been subjected to these kinds of RCTs. So a lot of the treatments that you're going to have questions about, I'm not going to talk about here. We can talk about them in the question and answer period, but they haven't been evaluated as carefully as SSRIs and CBT. So that's the first thing I'm going to say. The second thing I'm going to say, and again, it's a similar theme to what I just talked about, is that the story is very different for anxiety than it is for depression. And because of that, again, by treating anxiety, the hope is that that might be the best way that we can impact depression. All right. So let's talk about depression first. These are the bottom lines of the selective serotonin reuptake inhibitors: fluoxetine, which is Prozac, and citalopram, which is either Lexapro or Celexa. There's pretty good evidence that both of these medicines work. They both have FDA indications. There's weak evidence for sertraline, which is Zoloft. That doesn't mean if your child's on Zoloft, you should take them off. These differences are probably very minor. All the SSRIs probably work. None of them probably work all that well, and we'll talk about that in a second. There's some very weak evidence for paroxetine and virtually no evidence for all the other agents. And so there is some controversy about these medications, and the controversy relates to a lot of things, and we'll talk about the controversy. One of them is the use of the medicines, unfortunately, outstripped the amount of evidence that we have, all right? There is evidence that they work, and there is evidence that they're helpful, but it's not nearly as strong as we would like, all right? So that there's not enough studies, number one, and the magnitude of the benefit is not as large as we would like, all right? Another aspect of the controversy is how that message got contorted, and that has to do with some of the rules about advertising and some of the complexities about pharmaceutical companies that, again, we can talk about more about that. But the first thing to take away is that all of these treatments, they're okay, but they're not great for depression. So let's talk about psychotherapy, all right? So the best psychotherapy is something called cognitive behavioral therapy, all right? That's the therapy where the evidence is the best, all right? The most important study on the treatment of depression in children and adolescents is called the TAD study, the Treatment of Adolescent Depression Study. A study about 10 years old, a little less than that. This study compared fluoxetine, the best antidepressant, CBT, cognitive behavioral therapy, their combination, and placebo. And this shows you the data from the study. I'm going to very quickly walk you through the study. The key thing to know is that there were 4 groups. Kids came into the study, you flipped a dice that had 4 numbers on it. If you got 1, the child was told you either got placebo or you got fluoxetine. If you got 2, the child was told you either got placebo or you got fluoxetine, all right? So 1 or 2, the child is blind. The child doesn't know what treatment they're getting. If you got a 3, you were told you got CBT, all right? So the child knows they're getting CBT. If you got a 4, you were told you get the Cadillac. You get CBT and medication, all right? You weren't told that you could get placebo. So if you got the combination, you know that you're getting the best treatment. And in science of clinical trials, we call that an expectancy effect. So that's the important thing to remember. So what did the study show? So this shows decrease in depression symptoms over time. So if the line is lower, that means that it's better, all right? So remember I said that SSRIs are not great treatments? Unfortunately, the news gets even worse. So that first line that looks like 1 line, that's actually 2 lines. One of those lines is for placebo, and the other one is for CBT, all right? So yeah, so CBT in this very important study was no better than placebo, all right? The other 2 lines, the third line that's a little higher, that's for the fluoxetine monotherapy. Those are the kids who got fluoxetine but didn't know, all right? That was much better than placebo. So remember, I just said these are not great treatments, which they're not, but fluoxetine is still much better than placebo. Now, the big news story when this study came out was about that bottom line. It was about the combination treatment, which is the best treatment. However, remember what I said, that those kids know that they're on the active medication, all right? So the bottom line from this study, when you look at it, is that the most significant thing you would say among all these treatments, the most important thing is, if you have a child with depression, they need to be on an antidepressant. That's what this study would tell us, all right? That's really concerning news because I just told you that they're not that great treatments, all right? I will tell you, I start with the bad news. We will get to good news. All right, so that's the bad news, that's depression. The story's very different with anxiety disorders. Very different in 2 ways. Number 1, the effect of the medicines is much greater. So we can quantify the magnitude of a clinical effect with a number. A lower number is better. A perfect treatment gets a number 1, all right? The best treatments we have are between a 1 and a 5. SSRIs for anxiety disorders are about a 3. So they're very, very good treatments. SSRIs for depression are about a 10. All right? So the first lesson is that SSRIs are much better treatments for anxiety than they are for depression. The second lesson has to do with CBT. So this is the exact same kind of study, except instead of, and this is about 5 years old, except instead of for depression, this is for anxiety. And the findings are quite different. So the first difference, if you look at the bottom 2 lines, you see that green line and that yellow line. And the first thing is that for anxiety disorders, CBT is better than placebo. And when you compare the monotherapy, CBT alone, and the antidepressant, it was sertraline in this study, that's Zoloft, there's no difference. All right? So CBT and SSRIs work equally well. All right? So that's the first lesson. But then the second lesson is that when you look at the combined treatment, the bottom line, the difference between the middle 2 lines and the bottom line is much bigger than it is for depression. So because of this study, what I usually recommend if you have a child with an anxiety disorder is that you should start with CBT. Cognitive behavioral therapy should be the first line treatment. And if that child is not responding after a month or 2, then you should think about adding medication. Overall, most kids get substantially better, which is a very different story relative to depression. And one of the things that we do for any child who comes into our study at the NIH, they do get free CBT. Everybody does get free CBT. All right, so what's the bottom line? The response rates are much higher in anxiety than depression. More kids get better. And the relapse rates are much higher in depression. Couple final things to talk about. One of the big controversies in front of the FDA were these concerns about suicidal ideation. So this shows you data in about 40,000 kids. These are data we reviewed at the FDA. And the thing that you should look at is these dots that go down kind of slanting from the upper right corner to the left right, to the lower left corner. All right? This quantifies whether SSRIs or placebo give you more thoughts about suicide. If your dot is on the right, SSRIs give you more. If the dot is on the left, placebo gives you more. All right? And if you fall right on the dotted line, there's no difference. These dots are different ages, and as you go down the slide, the people in the studies get older. So what you can see at age 25, that's where the dot falls right on the line. There's no difference in terms of the risk for thoughts about suicide between the SSRI and the placebo. If you're older than 25, there's fewer thoughts about suicide on the SSRI. If you're younger than 25, there are more thoughts about suicide on the SSRI. All right? So this is a real thing. There is this tendency for kids on SSRIs to have thoughts about suicide, but it is still rare. It's more common than on placebo, all right? But it's what we call a small effect, all right? Much smaller than the effect for benefit. So I already told you that the medicines have a small beneficial effect in depression. The effect in terms of the risk for thoughts about suicide is much, much smaller, even than the small effect in depression. So what that means is you need to be aware of this. You need to be careful, but if a child needs an antidepressant, they should get an antidepressant because the chance of them doing better is much greater than the chance of them doing worse. All right, so what's the bottom line? SSRIs are very effective in anxiety. They're not as good for depression. This increased risk of thoughts about suicide is real, but the magnitude is small. All right, so in the last 7 minutes, I'm going to talk about neuroscience. This is stuff that I do, I love. It's really fun, really interesting. And these are the kinds of studies that if kids come, they can be in these kinds of studies. It's very new research. It's teaching us a lot about what ultimately causes these kinds of problems. Probably in my lifetime, and again, I used to say I'm really young. I'm not that young anymore, so this isn't that dramatic. In my lifetime, unfortunately, because this is so complicated and the research is so new, I do not think it's going to dramatically impact anything that we do with children. Any of the research that I'm doing is not going to dramatically impact. Probably the first thing that is going to happen, and we do have hints of this in the research that we're doing at the NIH, and I'm going to talk a little bit about this, we are going to discover new treatments. And we do have some signs of new treatments, and I'll talk about that. Yeah, we're not going to have new diagnostic tests, all right? And again, we'll talk more about this in the question and answer period. You should not be paying a lot of money for fancy diagnostic tests to diagnose a mental disorder. You should not be mailing away for genetic tests. Don't do that. And we can talk about why and why doctors are telling you to do that. You shouldn't do it. But again, we'll say more about it. So there are two main things that I do. We study the brain using a technique called fMRI. I'll tell you something about that in a second. But the biggest thing we do is we look at how information is processed in the brain, and this has a lot of importance for new treatments. So the big thing about fMRI, and the reason that I left Columbia to come to the NIH, is the promise of this technique, which was invented in the late 1990s. About 1997 is when I started doing fMRI. I came to the NIH in 2000. And the big thing about fMRI, it is completely non-invasive. And the reason that it's non-invasive is it capitalizes on this unique property of blood that changes its magnetic susceptibility properties when hemoglobin is attached to it. So what this gives all of us is this natural, what we call contrast agent. It allows, if you have a powerful enough magnet and computer, for us to non-invasively detect parts of the brain that are engaged when we do certain kinds of things. The main thing that I'm interested in studying is the brain's fear network. And the main stimulus that we use, and we can talk about why this is, we use facial photographs that you can see right there. And probably the most important insight that we have discovered related to functional MRI is displayed on this picture. So this picture is from the 1990s, so it's more than 20 years old. This picture is more than 20 years old. And this picture was based on theory from a neuroscientist named Joe Ledoux from studies in rodents and non-human primates. And the idea behind this theory, it had to do with attention deployment when we encounter threats, all right? So the picture of, you see this man walking through the woods, that's an example of what we call bottom-up capture of attention. So the idea here is the guy's walking through the woods, he's engaged in a neutral task, having a good time, and then this snake appears, and that snake captures his attention very rapidly. And the main insight that came out of research in rodents and non-human primates, again in the 1990s, was that this reflex operated incredibly quickly. And we now know we can think about it exactly the same way that you can think about the reflex when you pull your hand off the stove, all right? So when you pull your hand off the stove, what happens, you pull your hand off, and then 500 milliseconds later, you say, oh my goodness, the stove was hot. Well, it turns out that our attention system works that exact same way, and this sophisticated fMRI technique allowed us to discover that people who are anxious have this very rapidly deployed tendency that they are not even aware of to rapidly shift their attention towards a threat, all right? And we can detect this with fMRI. Now, the reason that this is important is people are unaware of the fact that they're doing this. They don't know that they're doing this. So telling them to quit doing it or trying to teach them how to not do it just by talking to them, it doesn't work because they don't know what they're doing, all right? So we and others developed this basically video game And you see the video game depicted here. It just uses faces and stars that kids have to find, and I'm not going to tell you how we do it, but the way the video game works is the kids have to play this game over and over and over again. So whenever kids come in for psychotherapy with us, before and after they see their psychotherapist, they play this video game, all right? And what we have found is that while the psychotherapy works in general, all right, kids who also get the video game have a brisker, greater, stronger response than kids who don't. And the way that we think about this, I already told you I love baseball. The way we think about this was my favorite book growing up. Ted Williams, who was my favorite player, and he wrote a book called The Science of Hitting, which at the time, those were my two favorite things. And most people don't realize this, but Ted Williams was a really smart guy, and he made the observation that whenever we have a rapidly deployed motor response, so probably the best example is trying to steer your car out of something that runs in front of your car, that's like a really good response. For Ted Williams, it was hitting a baseball. There are two components to that response, all right? One, we learn slowly and what we call deliberatively. So for Ted Williams, it was the strike zone. So he taught all his hitters, you have to learn the strike zone, and those red dots, that's where Ted Williams' best pitches were. So when he walked up to the plate, he was thinking to himself, I want to pitch in that location. He had all his hitters study what was their best strike zone. That's like learning the rules of the road when you're driving the car, right? You read about it, you learn about it, you learn how to do it. In psychotherapy, it's like teaching people to find a safe person, so the video guy for me. And if I get nervous, I'm going to look at the video guy and I'm going to feel better. All right? These are all slowly deployed, deliberative acts that we do. All right? But we don't teach kids how to drive, put them in the car and let them go, right? We don't do that. The reason that we don't do that is rapidly deployed acts have a second component. We need to practice them over and over and over again. And that's why it's not enough to just hear about driving a car. You have to drive it over and over again. And that's why Ted Williams taught his hitters that as you're getting to the plate, the strikes, forget about the strike zone. It's not relevant anymore. For you to master that moment, you've got to swing the bat thousands upon thousands upon thousands of times. And that's what we think these attention reflexes are like. We think it's very much like becoming a good hitter. You got to learn the strike zone, and that's what we teach kids with CBT. You learn it slowly by teaching, but then you got to practice this rapidly deployed act. And so that is the kind of thing where I think neuroscience is going to help. Now, it's much more complicated than that. I can tell you why if you have questions about it, and there are a lot of interesting stories about it. There are other novel findings. They're not as relevant, so I think in the interest of time, I'm going to skip through them, and I'm going to say, amazingly, I'm about to be over time, which I won't do. So I talked to you really about two things. I talked to you about different kinds of problems, what we know about their longitudinal course, their familial aggregation, and their treatment, and then I gave you a few clues about neuroscience. I gave you both, if you want to refer patients to any of our studies, that number, but that is people are always shocked when they call me or email me that I answer the phone. It's just me. That's kind of the way the government works, which it's not too bad. It's not too bad. But with that, I'll thank you for your attention, and I'll open it up for, I can stay, I gotta leave by like 5:02, so 45 minutes. Yeah. Yeah, so we work very closely with repeat the question. The question was about Dr. Shaw's studies of ADHD. We all work very closely together. We're all friends. I know Dr. Shaw quite well. We refer patients among each other. So if you call us for any of our studies and you say you want to be in as many studies as possible, you let us know and we help you do that. The big thing to know is not all the studies have treatment. So if you really want treatment before anything, say that right up front. My studies of anxiety do have treatment. Some of our studies of mood disorder have treatment. Most of the studies of ADHD don't have treatment. Oh, excellent question. The question was about tricyclic antidepressants. Didn't talk about that. The data, there are two big problems with tricyclic antidepressants. One is that the data are much weaker in children and adolescents, and it looks like they might not work at all. They do work for enuresis, bedwetting, and they might work for anxiety, but they look like they don't work for major depression. And the second thing there is that there are major concerns about the toxicity of tricyclic antidepressants, both in overdose, but there are some concerns that the autonomic regulation of the heart in children is different than it is in adults, and there's some concern that the autonomic effects of the tricyclics might be particularly dangerous in children. So they're like a third-line treatment in children. So that's another really big one. The question is, if a child's on an SSRI for anxiety disorders, how long should the child stay on it? And whenever anybody comes and sees me, one of the first things I say, and it's relevant here, is that socially and politically I'm a very liberal person, but scientifically and clinically I'm very conservative. So the things that I'm going to say are different from what you might hear a lot of other people say. I tend to be cautious, and I have another whole line of research on kind of brain development and the effects of the SSRIs on brain development. And there is some evidence that SSRIs affect brain development. Now, the evidence that anxiety affects brain development is stronger than the evidence that SSRIs affect brain development. However, because there is this evidence that SSRIs can affect brain development, I do not like children to be on SSRIs long term unless I really know they need to be. Now, I know the next question is, well, what's long term? So the way that I do it is every child who has had a year where they're relatively symptom-free, I have a discussion with the parent where I say, I would really like your child to come off the SSRI after a year. Now, you have to realize your child could relapse. What's the chance? About a third of the time, the child relapses immediately. About another third, they relapse with the first stressor. So 2/3 of the time, they usually relapse, all right? But there is a third of the time where the child's never going to need the SSRI again, all right? As a clinician who's conservative, I want to know that. Now, I also say you got to realize it could be really bad if your child comes off. They could get really, really anxious again, and you might have forgotten how bad it is. We'll be able to get them back to where they were, but it is quite common, and I have this discussion exactly like I'm telling you, where we take the child off the SSRI, it's terrible, and the parent says, you told me it was going to be bad, but gosh, I didn't realize it would be this bad. And there are some parents who say, I don't want to risk it, and I say, I'm okay with that. I'll continue prescribing. It's not what I would do. It's not what I would do. And parents also say, well, what's the point if 2/3 of the time he's going to relapse? What's the point? The point is to figure out if your child is in that 1/3 that doesn't need them. And I want to know that. Now, some parents say, I don't care. I would rather just leave the child on the medicine. And that's okay, but it doesn't, I feel uneasy about it. So, yeah. Questions about what's the incidence of comorbidity in anxiety and depression, all right? Among kids who are anxious, the rate of depression is about twice as high as it is in the community. So if the rate in the community is 5 to 10%, then the rate in anxiety disorders is 10 to 20%, not that high, all right? So most kids with anxiety are not depressed, all right? On the other hand, if you look at a child with depression, the overwhelming majority of kids with depression, much more than 60%, will have an anxiety disorder. So most kids with depression do have anxiety. However, most kids with anxiety don't have depression. Yeah. Yeah, question about how early will I put a child on medicine? It matters whether it's anxiety or depression. If a child has an anxiety disorder, I really want them to get CBT. I feel comfortable at 7. I will have children younger than 7, but each year below 7 I get more nervous. ADHD and anxiety is actually a less common comorbidity. It's particularly difficult to treat because the medicines that help anxiety often make ADHD worse, and the medicines that help ADHD often make anxiety worse. So what it really matters is what's the more serious problem, and it can vary from child to child. Yeah. Question was, are there age-related differences in the response to CBT? The short answer is no. No, it works just as well with little kids as it does with adolescents and adults. Now, some people suggest that that's not true, but they're really wrong. They're totally wrong. It's not even a debatable point. Some of the things that we're talking about are debatable points, like this SSRI effect on the brain. That is not a debatable one. The biggest predictor of who responds to CBT is whether a child can face the thing that they're afraid of. That's what for CBT to work. What a child really needs to do is they need to be exposed to the things that they're afraid of, all right? If they won't be exposed, the treatment doesn't work, all right? And that's what really predicts. And remember when I was talking about parents and factors in the environment that relate to anxiety? The biggest, most important one that we have found, you know, and if my wife were here, she would tell you this, I'm like the biggest wimp in the world. So whenever any kid is upset about anything, the last thing that I want to do is expose them to the thing that's making them upset. But the thing that we know from longitudinal studies within families, the biggest predictor of which kids get over their anxiety is parents that force their kids to do the things that they're afraid of. Those kids get better, all right? And I know. I did. My daughter, she would kill me if I was saying this. She's 22 now, but when she went to kindergarten, she was scared to death. What are we going to do? Everybody said, I literally picked her up, put her on the bus, sat her down, said, don't move, ran off and said, drive. And I hate to say it, that you do have to do that. That's what you have to do. Yeah, that is people. The comment was she's afraid she's going to scar her child. Me too, but the data shows that that's not what happens, number one. Number two, that's where a therapist really comes in handy. Therapists have a lot more experience knowing what's reasonable, and a therapist can help reassure you to be tough. That's where they're really good. So yeah, excellent question. Do I feel the same way about depression as I do with anxiety? And the answer is no, I don't. Remember what we said about depression, that it's frequently recurrent and it's much more difficult to treat. If I've had a child who was really horribly depressed, I finally got him better. We do have that discussion, but I don't say, hey, if he were my child, I'd take him off. I say, I really don't know what I would do. That's what I often say, and it kind of matters. If the kid's been well for a really long time, maybe they've had some side effects and their depression wasn't that bad, then I might take them off. If the kid was like, I've had some kids who missed 2 years of school, you know, and they're finally back on track after a good year. I can't ask that child to come off of medicine. So it's much more nuanced. Yeah. Question was about the evidence of the negative effects of the SSRIs. The best data we have are for thoughts about suicide. The magnitude of the effect is relatively small. Across all of these studies, there were a total, in about 10,000 kids, there were a total, am I answering the right question? Or?
Well, I was referring to more about brain development.
Oh, so the question was about long-term effects on brain development of SSRIs. The problem is these are all studies in non-human, my studies were in non-human primates, all right? Most of the studies are in rodents, and we really don't know how relevant they are. In the studies that I did, the thing that we found was that the SSRIs upregulated the number of serotonergic nerve terminals, and there are two things about that. One was this was a very long-lasting effect. When we took the monkeys off the medicine, we waited about 2 years, which is the equivalent of about 8 years before we scanned their brains, and we still saw this difference. So that's a really long effect. That's number one. Number two, there were no effects on behavior. So it's very hard to know what's a good effect and what's a bad effect. That's why I answered the question in a very non-directional way. We really just don't know. Yeah, sure. That's not quite what I said. The question was about age and SSRIs, and I said I feel totally comfortable at age 7.
Right.
I get increasingly uneasy with it, just because we know so much less. We know so much less, particularly in younger kids. I have given SSRIs to 4-year-olds, maybe 5 times in my life, and I've seen literally thousands of kids. And it's not a crazy thing to do, but it's something that you want to do very cautiously and thoughtfully. Yeah. So the question was basically what types of exercises and what types of things do you do in CBT? 2 things to say about that. Ron Rapee, R-A-P-E-E, has a book. It's like $10.99 on Amazon. It's called Parenting Your Anxious Child. All right. He is one of the real gurus of CBT. He's from Australia, great guy. If you buy that book and read it, it's basically how to do CBT, and it'll walk you right through it. The problem is these questions about am I scarring my child? The book can't tell you that. That's where you really need a therapist. But the basic thing that you want to do, you want to start out by making what's called a fear hierarchy. So you want to rate all the things that your child is afraid of, and you want to say to them, okay, we're going to come up with a plan that you're going to face all these fears, all right? We're going to start low and we're going to go up. Then what you want to do is you want to work with the child to teach them new strategies about what they can do when they feel afraid. So I love baseball. When I feel afraid, I think about my favorite player. I imagine all the base hits I got, all right? And then the real part that really works, you need to start low on that fear hierarchy, and you need to do exercises where you're with the child and they're exposed to the things that they're afraid of. So, and you got to be really creative about it, and that's also where a therapist comes in. We had a child at the NIH who was scared to death to sleep in the dark. So what the therapist did is started with like 20 different night lights, all right? And then every few days they would turn off one night light. And then, eventually the child was sleeping in the dark. And that's the kind of thing you want to do, yeah. So question is, what if it's less tangible, like death? That's where a therapist really can be helpful. You can come up with exercises where the child will think about death. Or you can watch movies where somebody dies. There are plenty of, what is The Champ? Is that the one where we used to have all these movies where I think the old John Voight movie from like the 80s, that was one we used to use. Charlotte dying on Charlotte's Bambi's mother. Yeah, and Dumbo, right? Dumbo and Mufasa, right? Yeah. So the question is, what if CBT doesn't work once? Is it worth trying again? The short answer is yes. It's definitely worth trying again. And there are 2 things to note. One is, particularly in adolescence, getting them more actively involved so that they make choices about what they want to do and how they want to do it can make a really big difference. And then the second thing is the therapist does really matter a lot, both in terms of their skill, but also what your kid thinks of them. So the best therapist, if the kid doesn't like them, it really won't work. So adolescents are often more willing to be part of that, Kids sometimes have a harder time with that, yeah. Yes, it can. So the question was the attention training, does it work for kids who are perfectionists? It does. I don't want to make too great a deal out of this. It is a good, helpful treatment, but we still have a lot further to go.
And how does it work? I'm not understanding.
So the way that it works is that we think that there's this automatic reflex that attunes the brain towards threats that kids automatically do. So the way the game works is that you have to find a prize. And what happens in the active form of the game is 2 faces flash up, say an angry face here, a neutral face here, and the prize is always behind the neutral face, always. hundreds and hundreds and hundreds of times. So what the kid learns implicitly, they don't tell you this, they don't know it, they learn that if they want to find the prize, if the face is over here, they better shift their attention over here because they'll find the prize. And they naturally learn how to do that. And the more they learn how to do that, and the greater their changes are in the brain, the better they get.
So what's the app?
What? There are apps. There are apps. And remember, I said I don't want you to use it. Here's why. And it is. I will tell you, it's one of the most interesting things that I've been involved in. It turns out that the relationship is a little more complicated than that. And we discovered this, that a lot of my work is done in Israel with colleagues from Israel. And one of the big interests that people have is in this kind of attention response in real danger. All right? So we did a number of studies in Israel, and it turned out that soldiers had the opposite tendency. All right? That when soldiers were in battle, they get this tendency to pay attention to threats on the exact same measure, all right? And the more they attend to threats, the better they did, the lower their risk for PTSD. So there was a big story in Israel just like 2 or 3 weeks ago, and this was my colleague. We did this study with 1,000 Israeli soldiers where we did an experiment where we randomly assigned them to get a training where we train them the total opposite way of how we're training anxious kids. We train them to attend towards threat. And those soldiers had lower rates of PTSD in the last Gaza war. So the big story in Israel is every Israeli soldier gets this training before they go into combat. They get totally the opposite of the training that we give the kids. Now, I will tell you, and I said this to my colleague, and I'm involved in the research, I think that's a bad idea. I think it's a bad idea that they're doing this in all these soldiers because we really don't know enough to do that. But the key thing is this one minor shift has you do totally the opposite thing in terms of the treatment that you're giving to an individual. So I get very nervous with apps that we're going to inadvertently make people worse. That's what I worry about. The other question that I often get asked that I really don't know the answer to, but I do get nervous about, if you saw our video games, we actually, our new one is better, it's more engaging, but they're really boring, right? If you think about that we're having a clinical effect from these boring video games, yeah, exactly. You can imagine the entertainment video game industry, it's not that hard to imagine that there would be bigger effects from more realistic games where threats are appearing all over the place. You know, it's soldiers trying to shoot you, that kind of thing. So, you know, it's not the kind of thing we're doing much research on, but it does make me nervous. Yeah. Yeah, question is, how long does a child need CBT before you think it is or isn't working? The typical course is 4 months CBT. You like to see an effect, some improvement between 1 and 2 months. So I don't worry at all if there's no change at 1 month. If you're getting past 1 month and there's no change, I start to worry. Yeah, question is, at what point do you say SSRIs are not working? Usually I like at least 8 weeks at a reasonable dose, and 20 milligrams of fluoxetine. And if somebody doesn't respond to 8 weeks at a reasonable dose, sometimes people will respond to a second SSRI. So usually you want to try 2. Oh, good question. Question is about neurofeedback. A lot of interest in it. Most of the work suggests it does not work. It does not work. So the thing that people are most interested in is neurofeedback for ADHD, and you can go pay for it. Most of the evidence suggests that it doesn't work. There are people who are trying to do neurofeedback with fMRI, and it is suggestive that it might be better, but it's not the kind of thing that I would pay for. Yeah, the question was, and I didn't say it that, so I'll no, that's okay. That's okay. I'm speaking very fast. But the question was, well, let me state the way that I'll ask the question. Would I prescribe an SSRI and a stimulant together? And the answer is, I would. The thing that I said is it's tricky. And the reason that it's tricky is that the two medicines make each other worse. Now, the nice thing is that we do have CBT. So my preferred approach for a kid with ADHD and anxiety is to manage the ADHD with medicine, because therapy does not work as well for ADHD, but manage the anxiety with cognitive behavioral therapy. Now, if the child doesn't respond, then an SSRI is fine, but you got to realize that sometimes then the ADHD gets worse. Yeah, it's a question of non-stimulant treatments, so atomoxetine, Strattera, that's the one in that context that works best. They're generally not as good treatments. They're not as good treatments for ADHD. There's so-so treatments for anxiety, not as good as SSRIs, but if you have a child who can't take a stimulant, won't do cognitive behavioral therapy, Strattera is a totally atomoxetine. Intuitive is another treatment for ADHD. It will not make anxiety worse. People used to think it would be helpful for anxiety. The evidence suggests not really. It won't make it worse, but not the data. It doesn't really.
So what does it do?
It helps attention and focus. Yeah, it is a blood pressure medicine, and there was a thought that it lowers arousal, but the data don't really support it. Other questions? Yeah. Oh, excellent question. If a child with suicidal or pubertal age boy has thoughts about suicide, what's the likelihood that they're depressed? No more than half. No more than half, all right? So maybe about half of kids with suicidal ideation will have depression. There are a whole bunch of other problems that they'll have. Probably the biggest one is substance use problems. That's the really big one. The other thing that's really frightening, you know, and this is why schools don't like to ask about suicidal ideation. It is unbelievably common. You know, any given day, 20 to 30% of kids are thinking about suicide, which is, I know, it's really amazing. And up to 10% in a given year are making a suicide attempt. Yeah, I know, it's amazing to think about it. So, yeah, I mean, I think I'm a good psychiatrist and I misdiagnose things all the time. I think the main thing is that particularly in a complex case where things are unusual, it's very hard to know what's right. And the most important thing is that you want a psychiatrist or a psychologist who's open to considering other things. So open to thinking about, did they miss something or not? In my private practice, most of what I do are second opinions. I do a lot of them. And you know, you can always tell a really competent mental health professional when they're eager to get a second opinion, which is usually.
Do you have availability for second opinions right now? Or?
Oh, not really, but you know, I'm kind of always closed. But whenever anybody's really stuck, any psychiatrist that calls me that I know that's reasonable, I always figure out a way to help.
And when you throw ADHD on that whole.
Yeah, it makes it even more complicated. Yeah. What's the youngest age that you can do CBT with a child? So the really nice thing about CBT is the most important thing is the avoidance part, all right? So you can do CBT with a 4-year-old relatively easily. Now the big thing is there's a lot of debate in the field about how important the C, the cognitive part are. There are some people that think it's really, really important. So like Phil Kendall is a big believer in it. There are other people like Ron Rapie or Wendy Silverman who think it's really not that important. The problem with young kids is it's hard for them to do the C part. That's what's really problematic with young kids. So how do you know you found the right person? That's a really tough one. You know that these are complicated problems. When you as a parent talk to them, they make sense. They don't, you know, they talk to you the way I'm talking to you. They give you knowledge, but they don't pretend that they know everything. And that when you question them, they take you seriously. You know, the other big thing is that CBT is the kind of thing that you need to do a lot of. So people used to ask me all the time, but they don't anymore just because I say what I'm about to say. They used to ask me to do CBT, and I always say, you don't want me to do CBT. You really don't, because it's not the kind of thing that's a big chunk of my practice. When you want somebody who's doing CBT who it's a big chunk of what they do, like at least half their time. That's what I want as a CBT therapist. Yeah. Again, 2 months is where you should start to see an effect. At 4 months, you really should see an effect. And then what often happens is people will do booster sessions. So after 4 months, they'll see the child once a month, maybe, something like that. Oh, yeah. Questions about anxiety and learning differences. There are strong relationships between anxiety and learning problems. They tend to be nonspecific in that you see learning problems with a whole bunch of different kinds of mental health problems. The thing where anxiety problems tends to turn up most on tests are with spatial things. People used to think that that had something to do with the brain, but it probably doesn't. It probably more has to do with most of the spatial tests are timed. And when you're anxious, it really tends to interfere with how rapidly you do things. So there is a strong relationship. It's kind of with a little bit of everything. All right, maybe two more questions. Yeah. Yeah, so the question is, why would you try two? And you know, they don't have their main chemical effect is the same, but it's not identical. There are other secondary effects. So that's one thing. The other thing is the timing of them, their half-lives and how rapidly they act is a little different as well. Yeah, the question was, can I say a little bit more about the spatial relationship with anxiety? It's that the spatial tests are timed. Kids with anxiety tend to do things slowly, so their problems show up on time tests. The first thing you said. Oh, maze learning. Learning mazes, or remembering block designs, or arranging blocks. You see a pattern of blocks and you got to reproduce that. There's a test that, if there's a psychologist there, they'll know which one this is, that has half white and half red blocks, and you have to arrange them in a certain sign. All right, 2 quick questions, 1 and 2, and then no more. Yeah. Question is there a relationship between handwriting and anxiety? Short answer is no. Yeah. There is a strong relationship between perfectionism and anxiety, but it can manifest in a million different ways. It can manifest in handwriting, but it's no more likely to manifest in handwriting than it is in, turning in your homework or feeding the dog, and so it's not a writing problem per se, it's a perfection problem. All right, last question. It's usually, is this depression? It's a child in anxiety, do they also have depression? And it can be a very tough call. Particularly, remember I said that we have this really high bar for depression every day, all day for 2 weeks. What if it's every day, all day for 10 days? What do I do with that? All right, and then the child's fine for a week, and then it's for 8 days. That is very common, and what do you do with that is really tricky.
And it's arbitrary.
It's arbitrary. It's arbitrary.
SSRI, right, depression or never?
If I see a child with depression, I start them on an SSRI. And then the question is, like you said, if it's arbitrary, if I get a kid with 8 days who's doing really horribly, am I not going to start an SSRI? No, of course not. I'm going to start an SSRI, but that's a judgment call. The question is, are there other diseases? There are, but usually you see other signs, and that's less common. That's much less common. All right, thanks a bunch. You have my phone numbers.